Hello and welcome dear viewers to the another informative video on steady state pharmacokinetics and bioequivalence studies. Many of the professionals find this topic difficult to understand. That's why I have selected this topic for making a interesting and informative video. So we will start with the basics of steady state pharmacokinetics. See, generally whenever there is a dosing to the patient, that means dosing of the formulation or medication, after some time the tablet or capsule gets disintegrated into the stomach and then the absorption starts. Then from that absorption the medicine reaches or drug reaches to the blood circulation. After that, the after the absorption, the distribution, metabolism and elimination starts. So that is the ADME of pharmacokinetics. But when there is a repeated dosing at specific interval, then the plasma concentration of the drug is maintained at a certain level, and generally that level doesn't change if the dosing interval and the dose is kept similar. And when the steady plasma concentration level is achieved, that state is called as the steady state. This is a very layman definition of the steady state. Suppose you have 10 chocolates and you are giving one chocolate to the another person or another uh, child. So you will have 9 chocolates, and if I give you the one chocolate, then you will have 10 chocolates. Similarly, you keep on giving one chocolate to the child and I will give you one chocolate. So you will always have 10 chocolates in your pocket. That means you are having a steady state. This is just a generalized example so that you can understand the thing. Whatever you are losing, you are getting it. So steady state pharmacokinetics and bioequivalence studies are the same. When the rate of drug input is equal to the rate of drug elimination, then it can be considered or said that the steady state is achieved. Whatever you are losing, you are getting it. That means whatever the drug elimination is there, the drug input is there. That means the rate of the input and the rate of elimination is similar. And this doesn't come from the first dose or second dose or third dose. Generally, the achievement of steady state requires minimum 5 to 6 half lives or 5 to 6 dosings, and after that the steady state is achieved. When the drug is given repeatedly with the specific and regular intervals with specific defined dose, then the steady state is achieved. Also, in a generalized language, you can consider that the dose is equal to the plasma concentration. Simply, you can say that if you are giving a 250 mg of the dose, that time already the whatever the as per the bioavailability of the formulation or drug, the same dose is available in the plasma. The concentration around which the drug concentration consistently stays is called as a steady state concentration. See, this topic is little bit lesser known to the people, and this topic may be little bit lengthy, but keep your patience and try to understand these terminologies. You can watch these videos repeatedly, 2, 3, 4 times you can watch, and then you will get the clear understanding. Now, what are the steady state parameters? See, in the generalized way, we can say that the AUC, Cmax and Tmax are the pharmacokinetic parameters. These are parameters for the single dose studies. Once you give the dose, you measure the AUC, you measure the Cmax and Tmax, and from that information you can get the understanding about the pharmacokinetics of the drug. But in steady state, the terms are little bit different. The basics is same, but the terms are little bit different. Whenever you will face or you will see SS, that means steady state. The abbreviation is SS, that is the steady state. First of all, the plasma concentration at steady state is called as CSS, and that is the average plasma concentration at the steady state. That means the steady state is achieved, and after achieving the steady state, whatever the plasma concentration is there, that is the average plasma concentration, that is known as CSS. Now AUC 0 to tau and 0 to T. You might have seen the AUC 0 to T, 0 to infinity. So here the 0 to tau is there. That means the interval. You have given the first dose and you have given the second dose. You are repeating the doses, and in between the doses there is an interval. So that AUC is measured, and that is called as AUC 0 to tau. So 0 to tau means AUC during a dose interval at steady state. Suppose here I have given one dose, then second dose, then third dose, fourth and fifth, then sixth. So after 4, 5, 6 dosing, the steady state is achieved. So after 4 to 5 half-lives of the drug, the steady state concentrations are achieved. These are also known as the multi-dose pharmacokinetic studies, because these are the studies which involve the administration at multiple time points. Then Tmax SS. This is the time until the Cmax is reached, and Cmax is steady state Cmax. Then T half or T1 by 2, plasma concentration half-life. Cmax SS, maximum plasma concentration at steady state. C tau SS means concentration observed at the end of dosing interval at steady state. Here the steady state is achieved, and C tau SS means concentration observed at the end of dosing interval at steady state. C tau means concentration observed at the end of dosing interval. C average SS, it is the average concentration observed during dosing intervals at steady state. So it also involves the AUC 0 to tau divided by tau. That is the average concentration. So here you can see the area under this curve can be the AUC 0 to tau. This is also 0 to tau, this is also 0 to tau, this is also 0 to tau, but after attaining the steady state, consider here, this area will be AUC in the dosing interval. Here it will be the Cmax, and the time till reaching the Cmax SS will be Tmax SS. Then degree of fluctuation. Degree of fluctuation means how much fluctuation is there in the dosings. That means dosing interval are there, and how much concentration fluctuation is there along the intervals, that is fluctuation. Now the formula is Cmax SS minus C min SS, whatever the maximum concentration minus minimum concentration divided by average concentration, and all these are at steady state. Fluctuation indexes peak to trough fluctuations called as the ratio of CSS max minus CSS min to the CSS average at steady state according to the recommended dosing regimens. The degree of fluctuation in the plasma concentration during the dosing interval increases with increasing dosing interval, clearance, and the absorption rate. So this is very common that the fluctuation will be more when there is a fluctuation or change in the concentration during dosing interval. If the dosing interval increases, or with the increasing dose or dosing interval, then if there is a change in the clearance and the absorption rate, that time the fluctuation will be more. And here you can see the C mean, then dose is given, here C max, then it came down, once again dose is given, once again it went up, once again it came down, once again dose is given. So like this, multiple C max will be there, multiple AUCs will be there, but after achieving the steady state, the concentration will be in the specific range and that will be steady. So this is called as steady state. Here you can see CSS minimum, CSS maximum, CSS average. So this fluctuation is called as the degree of fluctuation, and here the formula is C max minus C mean divided by C average. Then another terminology is swing. Here C max minus C mean is done. Here also C max minus C mean is done. Here divided by average. Here divided by minimum. So this is the difference between the degree of fluctuation and the swing. Now, for multiple dose studies, applicants should document appropriate doses administration and sampling to demonstrate the attainment of steady state. See, whenever there is a bioequivalence study which involves the steady state study, that time the applicant has to show that in the study or bioequivalence study, the steady state is achieved. And how the applicant will show that the steady state is achieved? That is by showing the pharmacokinetic parameters. See here, the plasma concentration is given versus time is given, first dose is given, and like this dosings are going on. Here, after how many doses? 1, 2, 3, 4, 5, 6. Around 5 to 6 doses, the steady state is achieved. So the pharmacokinetic parameters will be into two types, primary and additional. So primary parameters will be Cmax SS and AUC 0 to tau. 0 to tau SS means here from this point to this point or this point to this point, the AUC will be calculated and that will be your AUC 0 to tau. 0 to tau means in the interval. Then Cmax SS. What is the Cmax at steady state? Additional parameters will be C tau SS, C mean SS, C average SS, degree of fluctuation, swing, and T max. So these are the additional parameters, and based on these parameters, the applicant will say that, or applicant will provide the data for justification of achieving, or for data for achieving the steady state in their bioequivalence studies. Now consider the accumulation of the drug into the plasma or into the tissues or into the compartments of the body. The drug accumulation occurs with repeated dosing and there is a delay in time to eliminate the drug from the body. That is called as the accumulation. That means once the dosing is given, the drug goes into the plasma, it goes to the tissues and get accumulated into the tissues, bind to the cells and receptors, may get stored in the adipose tissues, and from there it will take more time to go to the elimination. And when this occurs, that time it is said that drug has accumulation kinetics. Also, for some times the loading doses are given and the maintenance doses are given. Loading doses are given so that the drug get absorbed and get accumulated, and after accumulation is completed, the maintenance doses will give the steady state level. So that is a separate topic, how the loading doses and maintenance doses are given. And for loading and maintenance doses, there is a requirement of understanding the pharmacokinetics of the drug. Now we will see what are the factors which affect the steady state. So these are the drug clearance and half-life, dosing interval, and the dose. The drug clearance and the half-life will certainly have the impact. Drug clearance, that is indicated by Cl, is the rate at which the drug is eliminated from the body. And if the clearance is slow, more drug will accumulate into the system or into the body, and the Cmax, CSS, that means concentration at steady state, will be higher. If the drug is eliminated from the body at a faster rate or clearance is the faster, then the CSS will be lower. Then dosing interval. The dosing interval affects steady state concentration in a proportionality. That means there is a direct relationship with the dosing interval. The more frequently the drug is given, the higher the steady state concentration values. And this is very simple to understand. Now dose. Higher doses will increase the CSS value and lower doses will decrease. The dose required to reach and maintain the steady state depends on the drug clearance rate. Now these three factors are interrelated, like half-life, clearance or elimination kinetics, dosing interval, and the dose. So if the dose is higher, CSS values will be higher. But once again, if the clearance is higher, then these values will come down and dosing interval will be more. Now half-life and time to reach the steady state. How much time is required to attain or achieve the steady state? That depends on the half-life. And half-life is the time, or half-life is how long it takes for half of the drug to be eliminated from the body. Suppose if you are taking 100 mg dose and it is coming to the 50 mg in 2 hours, then half-life is 2 hours. For example, the drug has a half-life of 24 hours. The dose is 250 mg and is given every 24 hours time interval. Then how much time will be required to reach the steady state? Now we will see that. Steady state means the rate of input is equal to the rate of elimination, and in other words, body contains 250 mg at a steady state as per the bioavailability of the 250 mg. This is very simple definition. Now first day you have given 250 mg of the dose. In the morning 8 o'clock you have given 250 mg to the patient. That time that body or subject body will not have any of the drug, because you are administering the drug at the very first time. Now the once the dose is given, the absorption will start and half-life is 24 hours. Then at the second day on 8 o'clock you will give another dose. So considering the half-life of 24 hours, 250 mg divided by 2, that is half-life, it will become 125 mg in the body already from the first day, and you are giving 250 mg once again. So consider it as 125 mg from last day 250 mg for today. On the second day, it will become 375 mg. Then come on third day, you will have 375 mg divided by 2. Then on the another day, you will be having 437.5 mg divided by 2, that is 218.75 mg. This is the fourth day. And on the fifth day, what is happening we will see. Now you have 468.75 mg divided by 2 is equal to 234.375 mg in the body already from the fourth day, and you are giving once again 250 mg on the fifth day. Now out of 250 mg, body is containing 234 mg. That means 93.75% steady state is achieved. Because now the body contains the exactly the same, sorry, not exactly, little bit, means exactly means 93.75% of the dose which is going to be administered. Now coming to the sixth day, it will contain 96.87% of the administered dose already into the plasma. On the seventh day, it will contain 98.43%. And like this, the plasma concentration will go on increasing, and it will remain into the this range 98, 99, 19, 101, like this it will be coming. So that means you are achieving around 93.75% of the steady state after fifth day dosing. So that means generally the steady state can be said to be achieved after 5 to 6 half-lives of the drug, or after 5 to 6 dosing periods. So this is very simple now. Whatever the half-life is there, you administer the dose, divide it by 2, as the half-life is t by t 1/2, so that you will have the exactly half concentration of the dose administered at the second half-life time, and at that day you are going to administer the another dose. Consider these dosing are same. If loading and maintenance dose is there, then the steady state will be achieved little bit faster, or in 2-3 doses only you can get the steady state achievement. But if the doses are similar and the dosing intervals are similar, that time at least 5 to 6 half-lives will be required to reach the steady state. Then what is the importance of the steady state studies? See, generally the innovator or reference formulation companies, or the NDA holders, or you can say as a reference product manufacturers or researchers, do these steady state studies to understand the dose and the dosing intervals in the different populations. Different population means different patients, because the pharmacokinetics depends on the metabolism, elimination, and the organ functionality of the patients. That's why these different population patients are considered for the steady state studies, so that the state, after doing the steady state studies, we can arrive at the safe dose and dosing intervals. For example, if the patient is suffering from the kidney disease, and due to the kidney functions or lesser kidney functions, the drug is not getting eliminated out of the body, that time the drug elimination will be lesser and drug will stay more time into the plasma, so that to arrive at the safe dose and the dosing intervals, these steady state studies are done for the reference formulations in different population of the patients. Then reaching the steady state concentration is generally necessary for the therapeutic outcome. some of the molecules are there, or some of the treatment regimens are there, which involves the attainment or achieve or to reach the steady state concentration to get the therapeutic benefit of the therapy, like treatment of the infections and the cancer treatment. Then it is also required to understand the drug-drug interactions, because once the steady state is achieved, the patient will be receiving the medicine, and the same patient may receive the other medicine, so that the drug-drug interaction should not be there. So to understand the drug-drug interactions, the steady state studies are done. And in the similar way, the safeties and toxicities can be studied by the steady state studies. Now, steady state bioequivalence studies. See, for some of the formulations, the bioequivalence studies are required in the steady state. And when these are required, whenever there is a safety considerations which suggest using patients in the bioequivalence study who are already receiving the medication, often the only approach is to establish the BE without disturbing the patient's ongoing treatment is in a steady state study. For example, uh, the drug is anti-cancer formulation, or the drug is anti-cancer drug, and that drug is to be given in the treatment cycles. For example, 7 days cycle, then another 7 days cycle, or 21 days cycle, or 15 days cycle. That time the steady state will be achieved due to these treatment cycles. And the anti-cancer treatments or anti-cancer medications are cytotoxic in nature. Some of the formulations and APIs are cytotoxic, and to study those cytotoxic molecules, the patients are required who are already receiving the treatment. In that case, the steady state bioequivalence is considered necessary. Then if a steady state study is used, it is recommended that the applicants carry out the appropriate doses administration and sampling to demonstrate that the steady state is achieved, and that is justified, or that is proven based on the pharmacokinetic parameters. Also, whenever there is a toxicity related to the API, and if the formulation is going to be repeatedly administered, that time also steady state studies are required. Then if the drug shows uh, accumulation kinetics, that time also steady state pharmacokinetics studies are required in bioequivalence studies. So this topic is very important to understand regarding the steady state pharmacokinetics and the bioequivalence studies. And bioequivalence is a topic of great interest in the interviews. I hope you might have got a good learning out of this video. Keep watching the videos from Pharma Learning in Depth channel. Please do like, share and subscribe to this channel. Thanks for watching.